Hello everybody, my name is Dr. Fatma Mohammed Saeed. I am a lecturer of Endodontics at the Faculty of Dentistry, Cairo University. I'm glad to be with you this year in the 5th year endodontic curriculum. Hope you enjoy it, inshallah. Our lecture for today is a very important lecture, which is diagnosis. I bet you maybe study diagnosis in all other branches of dentistry because it's very important. A proper diagnosis will lead to a proper treatment plan. It will lead to a proper management of the patient. What differentiates a dentist from a dentist, or what makes a perfect dentist, is his ability to diagnose well, to know the cause, so he can treat the patient. Well, the word diagnosis, what does the word diagnosis mean? Actually, it is a word made of two parts, dia and gnosis. It means through knowledge. Through the knowledge you acquire from your studying, from your reading, and also through the signs and symptoms the patient says in your clinical examination, you finally come up with what does the patient really needs, what's his complaint, and you can then say how can you will treat him, the perfect treatment plan for this patient. This can occur by the data about the patient and complaint you acquire using your senses, by observing the patient, hearing the patient well, touching and examination, and sometimes smelling like foul odor or whatever. So again, diagnosis is the art of identifying a disease. It's really an art. It's really an art. And what differentiates an ordinary dentist from a clever dentist is being able actually to identify the real disease, the real complaint of the patient that may be masked by other factors. So it is the art of identifying a disease and differentiating between diseases with similar signs and symptoms, differential diagnosis, through the collection of data and information which are analyzed to reach a final conclusion that will lead a proper treatment planning. This can occur through scientific knowledge, interest, patience. For sure you will need a lot of patience with some patients, and sense and curiosity. Our chapter is composed of three major parts. The first is the patient information, the clinical examination, and the lab investigations if needed. The patient information contains the general information of the patient, his chief complaint, his medical history, and the past and present dental history, while the clinical examination contains the extraoral examination, the intraoral examination, and the diagnostic aids, and the lab investigations where there are some blood investigations needed in some cases. We will cover up all these titles, inshallah, in our lecture. First of all, the patient information. Why do I need the patient info or the patient information? This is a sample of the diagnostic chart for a patient. First, when the patient comes to the clinic, you give him a chart, write his name, his age, his sex, occupation, and phone number. Why do I need these? Why do I need these? Actually, the patient name and phone number for communication. The patient age. The patient age can tell me about the status of the patient. For example, if a very old aged patient and he's going through an endodontic treatment, I may suspect some calcification, some narrow canals. On the contrary, if there is a young patient, I may suspect that the canals are large and wide, maybe some bleeding, extra bleeding because of the young pulp. All this is related to the age. The sex, some problems may be related to male or female. However, females are usually more emotional and might experience more pain. The occupation, because some occupations actually are affected by the state of the teeth. such as politicians, movie stars. Some occupations need to bite on the teeth, such as the carpenter will bite on nails. It may to chipping of the teeth. So by knowing the occupation, you will know how will you make your treatment plan. The second part is the chief complaint. This is what made the patient come to your clinic. This is the patient chief complaint. It is always written in the patient's own words. You don't write the chief complaint as it is reversible pulpitis, or it is a caries in whatever tooth. No. The chief complaint is always written in patient's own words, such as the patient have pain related to upper right premolar area, lower left molar area, and it is always written in patient's own words. So you will actually find that there are many expressions for one thing. Say for the word pain, some people just come to say I have pain. Another one may come to say السنة دي بتلمع عليا. Another one may say في نشر في أسناني. All these في صاروخ. All these are the same expression or the same meaning for the word pain. And if I have pain, I should know the history of the chief complaint and the character of this pain. It will come up with us the next. Then the medical history. Why should I know the medical history of the patient? How it will affect me? Actually, you should know the medical history before you insert a single thing in the patient's mouth, before you even have to put on your gloves, because it's very important. What of this if this patient had an infectious disease? What if this patient had an epilepsy, or had a past trauma, fear, whatever, that he may just faint when you touch him? So you must know the medical history before even you touch the patient. Medical history can tell us about the current status of the patient, if he has any illness, if he has any allergic history or allergic to something, if he's taking any medications that would affect our work, if I need to consult with another physician, say a patient who have heart problems, kidney problems, liver problems, and I don't know if my anesthesia or drugs I want to prescribe would complicate the case, or would conflict with his medications, so I have to consult his physician. This is why medical history is of prime importance. The past dental history. I should know what does the patient have in his mouth, restorations, crowns, extractions. What is his attitude towards dental treatment? It actually is very important. It can complicate my treatment if the patient had a bad dental experience with another dentist. If he had allergy to one of the materials we use, if he had a traumatic extraction, as we say, if he had calcifications while doing endodontic treatment in another clinic, I should know all the past dental history of the patient. If there was a swelling before, if there is a recent restorative treatment done that was not done in my clinic, so I can know the exact state of the pulp. And here comes the present dental history. Actually, this is the history of the chief complaint. The chief complaint in the endodontic department usually comes in two forms: either pain or swelling, or pain and swelling. The patient comes, there is severe pain, there is mild pain, how can I know the exact diagnosis? This is by knowing the present dental history. I must know the nature of the pain. Is it aching? Is it throbbing? Is it stabbing? ساعات العيان يجي يقول لك ده بينبض. This is throbbing pain. It's an indicative of irreversible pulpitis. Sometimes he comes to say في سكينة في أسناني في حاجة كأن بالظبط stabbing pain. I must know the location. Is it localized? Is it diffuse? Is it referred from one arch to another, from one tooth to another? The onset, is it sudden or gradual or spontaneous or provoked? Does anything aggravate the pain? Thermal changes, drinking hot drinks, or only cold drinks, or even the water from the tap, or normal water from the tap, is it an aggravating factor that aggravates pain? The duration, is it momentary or lingering? Lingering means that the pain does not subside after removal of the stimulus. It continues for several minutes, hours, whatever, according to the case. Actually, lingering pain is also an indication of irreversible pulpitis. Is it intermittent or continuous? The frequency of the pain. Does the patient took any medicaments? Is there any relieving factor? Some patients come and say, oh, I took a lot of analgesics yesterday. I can't sleep. Analgesics are not working anymore. And some patients just say, when my tooth hurts, I will feel I want to put an ice pack on it. All these are indications of what the diagnosis may be. Now we come to the clinical examination. First, the extraoral examination. Why do I need the extraoral examination? Actually, some extraoral signs and symptoms may relate to intraoral diseases or may relate to some medical conditions I should be aware of. So I should examine the patient just from coming into the clinic. I watch his gait. His gait means the way he walks, his consciousness. I see the color of the skin. Is it normal? Is it yellowish? His sclera. Is it yellowish sclera or clear one? Because this yellowish discoloration may indicate some liver diseases, which actually may indicate that the patient have hepatitis or any infectious liver diseases I should be aware of. I should examine his nail and hair, because also some dysplasia cases have also some nail and hair problems. I should examine the lymph nodes to see if there is any infection, if there is palpable lymph nodes, or and if it is hard, indurated, or soft, related to which part, to know if there is infection coming from which part of the face or the neck. I should see if there is an extraoral swelling or facial asymmetry, and if there is a localized swelling or a sinus tract. All these makes extraoral examination a very important part. Then the intraoral examination. Actually, intraoral examination in your book, you will find it in about 2 pages. I believe that while studying, if you want to study well, you should collect all the info in front of your eyes. So it is a very important tip that you collect everything you study related to each other in one part. And this occurs through either you put it in one slide or one paper, as you will see, or you put it in a table, as you will see later. You will find studying it is very, very, very easy. Okay, now we can see how. Intraoral examination. The first is the visual for the soft and hard tissue. I use my eyes. Why do I need visual examination? I can see if there is swellings, if there is discolorations, caries, fistulas, fractured discolorations, traumatic occlusion. All this I can spot it by my eyes. Then comes the percussion test. Percussion test. Percussion test, I use the back of the mirror. I tap on the tooth to see if there is pain or not. Actually, this test will be positive only in case of the presence of periapical inflammation. In which cases do I find periapical inflammation? In cases of periodontitis, apical periodontitis, or its advanced state, which is a periapical abscess. So percussion test will only be positive if there is an inflammation at the apex of the tooth. Any other inflammation in the pulp rather than the periapical inflammation, the percussion test will be negative. So again, percussion test is only positive if there is an inflammation at the periapical area, periapical tissue, such as periodontitis or abscess. It is done by using the back of the mirror by tapping the tooth. How would I know if my diagnosis or actually the results of the percussion test are valuable and right? I should first test the contralateral tooth. Say I want to make percussion on the upper right lateral incisor. So first I make my test on the upper left lateral to see the normal response of the patient. Then I do my test on the upper right lateral and compare between them. Why do I do this? Some patients, they are they become tense. Okay, they can just jump on the chair once you put a mirror in their mouth. So this will not indicate or will not give you a good indication about the state. It will mislead you. So actually, I want to test the normal response on the patient on a normal healthy tooth. Then I go test my suspected tooth. The third test is the palpation test. Here, when I wear my gloves and I'll start to go inside the patient's mouth. It's done by your index finger. You just move your index finger in the vestibule over the apices of the tooth. What will the palpation test tell me? It will tell me if there is a swelling, and if there is a swelling, is it fluctuant or indurated? It will let me know the normal landmarks and differentiating it from pathological conditions or swelling. It's very important test actually. Then the probing test. I get my periodontal probe. I measure my probing depth all around the tooth, maybe for reading. It gives me an idea about the periodontal attachment, and I can differentiate between endodontic lesions or diseases and periodontal diseases. The last one is the mobility test. Well, I get two hard objects, like two metal objects, maybe the back of the mirror and a condenser, two backs of mirrors, and I put them on the tooth and move my hands forth and back to see if the tooth is mobile. Well, actually the tooth has a natural mobility limit, minute one. As the periodontal membrane acts as a cushion, there is natural limit for its mobility. Mobility has grades. Some grades can be treatable, some grades can be curable. However, some grades are doomed, or the tooth needs to be extracted. Grade 3 is contraindicated for any treatment. It has a very poor prognosis, and the tooth may need to be extracted. Actually, grade 1 and grade 2 can be treated, and by periodontal treatment, actually they can go back to the normal periodontal movement or the normal mobility limit of the tooth. Well, here comes the diagnostic aids. These are some extra tests or materials or whatever needed to come up to the final diagnosis, the proper final diagnosis. First of all is the radiographic examination. As we all know, endodontic treatment needs a lot of radiographs. Radiographic examination is very, very, very important in our field. Actually, it's of prime importance. It uncovers what the dentist cannot see inside the bone. First of all, we have the conventional radiograph, and then came up the digital radiograph, which actually removed most of the disadvantage of the conventional radiographs, such as processing errors. The image can be modified, can be measured. A lot of advantages actually in the digital radiograph, but still these two forms of radiograph are 2D, two-dimensional. I cannot see the third dimension. Then came the panoramic radiograph, which shows a quick overview about all the teeth and supporting structure in the mouth. And the CT and CBCT, which actually is the 3D or three-dimensional image. I can see the length, the width, and the height of the teeth and supporting structure. It gives me actually a full image of what I'm treating, of the tooth, of a lesion, of a normal structure even, and the relation of all these with each other. Vitality tests. Vitality tests actually is composed of 4 tests. But here let's discuss first the word vitality. Vitality means that the tooth is living, that it has blood supply. Actually, vitality test is measured either by thermal tests, electric tests, or by what's known as laser Doppler flowmetry or pulse oximetry. Thermal tests and electric tests, they measure the sensory component inside the tooth. The tooth has many components. It has a sensory one, it has a vascular one. The vascular one from its blood vessels. Okay, so when I measure the sensory components by thermal tests and by electric test, well, it's better called a sensitivity test. It's not vitality. Vitality must measure something live, such as the blood supply. So what actually measures vitality is the laser Doppler flowmetry and the pulse oximetry. But يعني جرى العرف and they say all of these are vitality tests. So the second diagnostic aid with us is the vitality test. And again, when I want to make vitality to a tooth, I should test the contralateral tooth first to know the normal response of the patient, and then I would go back to my suspected tooth and make the test. First of all, the thermal tests to differentiate between reversible and irreversible condition. Thermal tests are either cold or hot tests, and this is the second form, which is a table, the second form that makes studying easier. I have a cold test with a lot of info for the cold test and a hot test for a lot of info for the hot test. When I put these in front of each other in a table, I can study it very easily. I can compare between them, and actually it takes no time in studying at all. This is a tip or a trick for you. If you wanna use it, feel free. Well, how do I make the cold test? I use a cold test agent such as Endo-Ice, which is ethyl chloride, or CO2 snow, ice rods, normal ice rods, or a cold water bath. Actually, what simulates the natural condition is the cold water bath. You do not eat Endo-Ice. Patients do not eat carbon dioxide snow. They eat, actually, they not eat ice rods. They drink water, cold water. So what actually simulates the patient is the cold water bath. But the application of the cold water bath in examination is hard. So we usually use the Endo-Ice or the CO2 snow. We apply these measures on the tooth after drawing, and we record the response. What would be the response? the response would be pain or no pain. If there is pain, I would say this is a positive response. No pain, there is a negative response. So first of all, I recorded the response. Then I will record the timing when this pain was relieved or when this pain vanished. But first, I would record if the patient had pain or no pain. Then I would record if this pain lingered with the patient, had time, or it just stopped once I removed the stimulus. In cases of normal palm, there will be a moderate transient pain, just a moderate pain that will disappear quickly after I remove my stimulus. In case of reversible pulpitis caries, there will be sharp pain but will subside quickly. In cases of irreversible pulpitis, it will have sharp shooting pain that lingers even after removing off the stimulus. And of course, in case of necrotic pulp, there will be no response. Actually, cold testing is a very reliable method. Some studies now say that is even more reliable than the electric testing, but I must isolate all the soft tissue around the tooth and take care not to injure the soft tissue, as very cold instruments or very cold measures may cause burning of the gingiva. On the other side is these are examples of the cold testing, the endo ice and the ice rod. On the other side is the heat test that can be done by hot gutta-percha or hot green compound stick, the one like you use in the pieces usually, a hot condenser or hot water bath. And as we said before, we must isolate the soft tissue. Imagine that you heat a condenser up to a very high temperature, it became red, and you put it on the gingiva of the patient. Ouch! It hurts, and a large burn will develop. So please take care and isolate the soft tissue. When the patient complains is with hot and cold and he cannot identify the tooth, the best test is the heat test. We should record also the positive or negative response and the time that the hot sensation took to stop. Either it lingered or it vanished quickly. Now, the second type of the vitality test is the electric pulse tester. The electric pulse tester depends mainly on an electric circuit. As we can see in this picture here, this is the device and this is the rod that will be put on the tooth, and it has two cords, one with a clip that's it has one cord, with a clip that will be hanged in the patient's cheek. Electric pulse testing is also used to differentiate between reversible and irreversible conditions, but as we said before, it measures the neural element. So the positive response denotes the presence of neural elements, and actually neural elements are the last element to disintegrate in the tooth. So the tooth can become irreversibly inflamed and even partially necrotic, and the neural elements are still alive. So it is not the best indication for the state or the vitality state of the tooth. Also, it doesn't give any information about the vascular supply. As we said before, it should not be used with patients having a pacemaker, and in multi-rooted teeth, if just one canal was vital, it will give a false positive response. So we should take care when using electric pulse testing. And attention please, electric pulse testing may sometimes give a false positive response or a false negative response. What is a false positive response? A false positive, it means that it gives me an indication that the tooth is actually vital while it is not. what is the false negative response? It gives me an indication that the tooth is doomed. It needs endodontic treatment. The pulp is necrotic, and actually in the actual state the tooth is good and can be treated, and it's in a reversible condition in most of the cases actually. So when it will give me a false positive response, for using the electric pulp tester, isolation is of prime importance. As we can see, there is a cheek retractor, cotton rolls. The tooth must be completely dry. If there is any moisture, or the electrode comes in contact with any metal object, it will give me a false positive response. Also, the patient's anxiety. Some patients are very anxious. You just put the rod on the tooth, they say, there is pain, and he doesn't feel anything. Actually, he's just anxious. Another cause is the liquefaction necrosis that actually leaves some liquids and pus inside the tooth that passes the electric current. It passes the electric current, leading to a reading, which is actually a false reading and a false positive response. The last one is the improper isolation, as we said before. And now what gives me the false negative response? The false negative response can actually occur if the patient is heavily pre-medicated. He is pre-medicated, he cannot feel pain even if the tooth is painful. Or there is inadequate contact between the electrode and enamel, so there is no current, there is no reading on the device. In case of recent trauma, actually after trauma, the neural elements undergoes a state of shock. The tooth will be not unresponsive to any current or to any stimulus maybe, so it will give you a false negative. Actually, if you try this test 3 months, 6 months later, you will find the response and the tooth is still vital. Then partial necrosis. If one root of a multi-rooted teeth was vital, it will give you and the others are necrotic, it may give you false negative response. And recently erupted tooth. As we all know, in recently erupted teeth, the neural element will not development will not be completed, so it may not pass the current, or the patient may not the patient will not feel pain. Neural elements are not developed while the current is running through the tooth, so it will give you a false negative response. Now we come to the laser Doppler flowmetry, which is one of the tests that actually measures the vitality of the tooth. It assesses the blood flow and the motion of RBCs. How does it work? Actually, there is a device or a light source that emits light. This incident rays falls on the moving RBCs. The moving RBCs reflect these rays that will be caught on a special photo detector, indicating the motion and the velocities of these RBCs, and indicates whether this tooth is vital or not. The last one is the pulse oximetry, which measures the oxygen concentration and the pulse rate in the blood. These are the actual vitality tests for the tooth. The last thing in our chapter mainly are the special tests. First is the bite test. The bite test is used to indicate if there is a fractured cast, a crack in the tooth. Actually, some patients come to our clinic with a chief complaint of severe pain. We make full clinical examination, we cannot find anything. The tooth is perfect. But the patient still complains and complains and complains, and may eventually lead to a large or a huge abscess at the periapical area. The cause would be actually a crack or a fractured cusp that we could not detect. So the bite test is used to diagnose cracked or fractured cusps or cracked tooth. It's done by using either cotton rolls, toothpicks, orange wood sticks, rubber wheels, and special devices such as the tooth. This device or any of these options are put on the cusp, the suspected cusp, and the patient is asked to bite. Pain occurs actually on releasing of the bite, not on biting. It will not occur on biting, but on the release of the bite, pain occurs, and this may indicate a fractured cusp or tooth, or a cracked tooth, or a cracked cusp. Then the cavity test. Actually, the cavity test is the last test I would use to differentiate between vital and a non-vital tooth. It's used mainly when the tooth has an extensive restoration or a crown, where I cannot use the thermal test, the electric test, the laser Doppler flowmetry, or the pulse oximetry. So I would go for a cavity test. Cavity test is done without anesthesia. The idea of a cavity test is that there is a part of the tooth that is very sensitive, which is actually the dentino-enamel junction. The dentino-enamel junction is very sensitive area in the tooth. So by using a small round burr, we make a small cavity till reaching dentine without anesthesia. If the patient felt pain, then this tooth is vital. If the patient did not feel any pain, then the tooth is non-vital. As we know, in the pain theories, they say that at the dentino-enamel junction there are a lot of nerve endings and anastomosis, so it is the most sensitive area in the tooth. Then the staining and trans-illumination test. It is usually used to detect also cracks that cannot be detected by eye. It works by applying a dye on the tooth, such as a methylene blue. This dye will stain the crack. It will enter between the crack parts. It will stain the crack, and by observation under a microscope or a bright light, the crack will appear. Selective anesthesia. This test is done when the source of pain cannot be identified. The patient comes to the clinic, I examine him, he is in pain, I cannot determine which tooth causing the pain, and sometimes I cannot determine which arch is causing the pain. As we all know, one of the properties of the endodontic pain is that it is referred. It can be referred from an upper tooth to the lower arch and vice versa. So when the source of pain cannot be identified by all other tests and all other measures, we would go for the selective anesthesia. How can I do the selective anesthesia test? For example, if I have two arches and containing two teeth that are suspected to be the cause of the pain, say an upper 6 and a lower 5, and the patient is in severe pain, I would anesthetize one of the arches, say the upper arch. If the pain disappeared, then the cause was the upper 6. If the pain did not disappear, then actually the cause was the lower 5. Again, if in a single arch, two teeth that are close to each other, and both of them had large restorations, had caries, had whatever, and I can't determine which one is the cause of the pain, I would anesthetize the most posterior one. The most posterior one. If the pain disappeared, then it was the cause. If it doesn't disappear, then I would go for I will know that the cause of the pain is the most anterior one. But for sure, this cannot be applied for the lower arch, because the anesthesia of the lower arch is the inferior alveolar nerve block, and the nerve block blocks the sensation from all the side, the half of the mandible. So I cannot anesthetize only one tooth. It can be applied to the upper arch.